Well, what about the lower extremity? Let's get into the lower extremities now. And this final section that we're going to go through in this program is going to be representative and illustrative of procedures that are required in both chapters 16 and 17, both of which involve testing of specific motions as well as specific muscles. But in this last section of the program, since we just did specific muscles in the last section, this section we're going to focus on specific motions, here using examples related to the lower extremities. So recall table 17.8 gives us the impairment values due to lower extremity muscle weakness due to non-neural structures. So we're testing specific motions as relates to injury to non-neural structures. Chapter 16 and chapter 17 also describe muscle weakness due to neural injury, but that's not going to be the focus of our discussion here. Here we're simply considering some type of a lower extremity injury that then results in weakness at either the hip, the knee, the ankle, or into the foot. In other words, non-neural injuries. And we're going to focus on those muscle weaknesses that allow for the greatest levels of permanent impairment for the balance of our muscle testing here. So let's begin with weakness to resisted hip abduction, which you'll notice carries anywhere from a 10% to a 25% whole person impairment. And if you think about that, 25% whole person impairment, that's roughly 1/4 of total impairment, simply for loss of function, grade 0 rating of hip abduction. So that tells you that the AMA guides consider that the normal function of hip abduction is essential for activities of daily living. Similarly, hip extension, ankle plantar flexion, and knee extension carry with them high impairment values. So let's focus our attention here on these specific motions of the lower extremity. So when we're talking about hip abduction, this is a specific motion that involves many muscles. Now, the prime mover involved with hip abduction is the gluteus medius. It also involves the gluteus minimus, the tensor fascia lata, and the upper fibers of the gluteus maximus, which act as accessory muscles. But the main prime mover of the hip in the direction of hip abduction is the gluteus medius muscle. So that's the muscle we're going to focus on for our testing. Now, the gluteus medius muscle has its origin on the outer surface of the ilium bone between the iliac crest and the posterior gluteal line dorsally and the anterior gluteal line ventrally. That muscle then projects caudal to insert on the oblique ridge on the lateral surface of the greater trochanter. And you can palpate this muscle on the side of your hip. You simply place your fingers on the greater trochanter of the femur bone and then raise your fingers superiorly, and that meat that you feel in that area, that is the gluteus medius muscle. So to test the gluteus medius muscle, we stabilize the pelvis on the involved side. So the involved side, we stabilize that pelvis because we want to make sure that we prevent pelvic lateral flexion, which would otherwise give the appearance of hip abduction. And this is one of those substitution movements that you need to observe for. And you prevent substitution by stabilizing the pelvis to prevent hip lateral flexion. pelvic lateral flexion. Then, with the subject in the side-lying position, the lower hip and knee, meaning the hip and knee that are in contact with the table, are flexed both to 90 degrees. This gives stabilization to the body against the table. The test limb, in this case let's consider the left lower extremity. The left lower extremity would lie on the table behind the right lower extremity with the hip in neutral and with the knee extended. The movement involves abduction of the hip without flexion and without lateral rotation of the hip. Both of those would indicate substitution movements. Then resistance is applied proximal to the knee joint on the lateral side of the thigh in the direction of adduction, which would be in the direction towards the table. And with a grade 5 rating of the gluteus medius muscle, we're going to see that with the person, with the examinee in the side-lying position, they're able to abduct their hip throughout the full range of motion without lateral rotation of the hip and without flexion of the hip, and they're able to sustain maximum applied resistance. And it's up to you, doctor, to determine what qualifies as maximum applied resistance. With a grade 4, we would see the same, although strength would be slightly less. With a grade 3, we see that the examinee is able to abduct the hip through range of motion, but not against resistance. And if you attempt to apply resistance, the ability to hold the test position gradually weakens. With a grade 2 now, the examinee moves to the supine position in order to eliminate the effects of gravity and horizontally abducts the hip through range of motion and without substitution movements of either hip rotation or hip flexion, but is not able to do so against any added resistance. With grade 1 and grade 0, we see increased weakness of the gluteus medius, and with grade 0, there is no visible or palpable contraction of the gluteus medius muscle. With the movement of hip extension, there are many muscles that contribute to hip extension. The prime mover is the gluteus maximus muscle, with the semitendinosus, semimembranosus, and biceps femoris muscles, collectively known as the hamstring muscles, contributing as accessory muscles. Again, the prime mover is the gluteus maximus muscle. So let's talk about these muscles. The gluteus maximus muscle has its origin on the posterior gluteal line and lateral lip of the iliac crest, posterior to the gluteus medius, and also has fibers that attach to the posterior surface of the lower part of the sacrum and the side of the coccyx and the posterior surface of the sacrotuberous ligament, and finally into the aponeurosis of the erector spinae muscles. So a broad band of origin. And that makes sense because it is a large muscle. The gluteus maximus has its insertion into the iliotibial band of the fascia lata, of the wide fascia, over the greater trochanter, and also in the gluteal tuberosity of the femur. And the gluteal tuberosity is a line along which the gluteus maximus inserts onto the femur. And I mentioned earlier that I was recently in dissection lab, and in this same lab we had some fresh femur specimens, and we had a femur specimen of a very active individual who died at 107 years old. And the gluteal tuberosity of the femur actually showed degenerative hyperostosis and degenerative growth, probably as a result of lifetime tugging and pulling on this insertion site, and a lifetime of tugging and pulling by an otherwise very powerful muscle that contributes to hip extension. The hamstring muscles are comprised of three muscles: the biceps femoris, the semitendinosus, and the semimembranosus. The biceps femoris originates on the distal and medial impression on the ischial tuberosity, and it inserts on the lateral side of the head of the fibula, with a small slip inserting on the lateral condyle of the tibia. So notice that this muscle crosses two joints. It crosses both the hip joint and also crosses the knee joint. The semitendinosus muscle similarly has its origin on the distal and medial impression on the ischial tuberosity, and it inserts on the anteromedial surface of the tibia at the proximal end of the shaft of the tibia. So this is also a two-joint muscle. The semimembranosus, it attaches also on the ischial tuberosity, on the superior aspect of the hip, above the hip, and it inserts on a horizontal groove on the posterior medial aspect of the medial condyle of the tibia. So that makes the semimembranosus the most medial of the hamstring muscles, with the biceps femoris being the most lateral of the hamstring muscles. It also inserts into a fibrous expansion into the fascia that covers the popliteus muscle, with a slip into the tibial collateral ligament, and then finally a slip into the fascia of the leg. So these three muscles, the hamstring muscles, have in common that they are all two-joint muscles operating at both the hip and at the knee. So to test hip extension, our examinee is going to be prone with the knee flexed greater than 90 degrees. Now let's think about that. What's the purpose of flexing the knee to 90 degrees? Well, when we flex the knee to greater than 90 degrees, this eliminates the action of the hamstring muscles and isolates the gluteus maximus muscle. Now, if you flex the knee greater than 90 degrees, hip extension may be limited due to buildup of tension anteriorly in the rectus femoris, which builds tension with increasing knee flexion. Okay, so once we have our position established, we're going to stabilize the ipsilateral pelvis to prevent pelvic rotation and also to prevent lumbar hyperextension, both of which would indicate substitution movements. The resistance is going to be applied to the lower part of the posterior thigh, just above the knee, in the direction of hip flexion, the purpose of which is to drive the thigh back down toward the table. In the presence of full strength, the patient is able to extend the hip through the entire range of motion and is able to sustain maximum pressure. With grade 4, range of motion is full, however strength is slightly limited, and it's up to you to establish how much limitation there is to the strength. With the grade 3, the range of motion is preserved. However, the examinee is not able to sustain the motion against added resistance. And when you palpate this muscle as your subject extends the hip, you're going to want to make sure that there's a contraction of the gluteus maximus muscle, because some people are not skilled at isolating specific muscles, and they may substitute hamstring action for gluteus maximus muscle action. And we try to eliminate some of the gluteus maximus contribution by flexing the knee. However, patients may not have adequate neuromuscular control to be able to isolate the gluteus maximus muscle, so it may help for you to palpate and press on that muscle and encourage them to contract this muscle, and they may get it if you palpate and poke and tap at the specific muscle. With grade 2 and grade 1 and grade 0, we see increasing weakness. Grade 2 is when the examinee is able to extend the hip only in the gravity eliminated position, in the side lying position. With grades 1 and grade 0, we see increasing weakness, and with grade 0, there is no visible or palpable contraction of the gluteus maximus muscle. And you can detect this because with a bona fide contraction of the gluteus maximus muscle, you'll see a narrowing of the gluteal crease. So that may help you to detect those cases where bona fide contraction is absent. Okay, let's go to ankle plantar flexion. There are many muscles that contribute to ankle plantar flexion, including the gastrocnemius, which is a two-headed muscle, the plantaris muscle, which may or may not be present, and also the soleus muscle. And recently in Dissection Lab, I was amazed at the thickness and the amount of meat involved and contained within the soleus muscle. And the soleus muscle had the ones that I observed had visible, meaning macroscopic, not microscopic, had visible muscle pennation, with the muscle fibers being oriented 45 degrees to the vertically oriented tendon that runs down the center of the soleus muscle. So an extremely powerful and anti-gravity muscle, the soleus. Now the gastrocnemius has its origin above the knee. There's two heads to this muscle. The medial head has its origin on a depression on the proximal and posterior parts of the medial condyle of the femur. And the lateral head of the gastrocnemius inserts on the lateral condyle of the femur with a slip projecting superiorly to the posterior surface of the femur. So the gastrocnemius muscle crosses the knee. So it therefore has action also at the knee. And both heads insert by common tendon into the tendocalcaneus, which itself then inserts into the middle part of the proximal surface of the calcaneus. The function of the gastrocnemius muscle is to produce 45 degrees of ankle plantar flexion when the knee is extended. And notice that there's emphasis that the knee must be extended. When the knee is not extended, or say when the knee is flexed, the two heads of the gastrocnemius that cross the knee joint become slack or loose, and muscle strength of the gastrocnemius becomes compromised. So to test the gastrocnemius, remember earlier in the program when we talked about the leverage systems of the body, the testing of ankle-resisted plantar flexion is a test of a second-class lever, much like a wheelbarrow. And that is a leverage system that carries tremendous mechanical advantage. And that explains why you can carry hundreds of pounds of loads in a wheelbarrow with very little effort, actually, depending upon the length of the handles of the wheelbarrow. So testing ankle plantar flexion with your injured worker supine, using your hands to try and dorsiflex the ankle, is not going to cut it. especially in cases of grade 4 and grade 5 where there is good strength present. So to accurately and adequately test ankle plantar flexion, have the patient standing and ask them to rise up on their toes, and make sure that they do not incline the body forward and flex the knee, thereby using the quadriceps to jump up and unweight their body so as to get up on their toes. Inclining the body forward and flexing the knees would be one physical exam finding for weakness of ankle plantar flexion. And we will describe what it means and how you can determine if there is normal strength, good strength, fair strength, or poor strength in just a moment. The plantaris muscle, when it's present, has its origin on the lateral supracondylar line of the femur. That's origin right above the lateral condyle of the femur. And it also inserts on the posterior surface of the calcaneus through the combined Achilles tendon. And in combination with the gastrocnemius, it contributes to ankle plantar flexion when the knee is extended. And I actually had a workers' compensation case where an injured worker ruptured his plantaris tendon. He stepped backwards into a pothole or a chuck hole that he didn't know was there, strongly dorsiflexed his ankle while his knee went into abrupt extension, and he snapped the plantaris tendon. Now, when we test the plantaris, there's no way to isolate the plantaris. It simply contributes to ankle plantar flexion along with the gastrocnemius. So that is tested by having the subject rise up on his toes. And then the soleus muscle has its origin now not on the femur. Rather, it attaches on the head of the fibula, on the proximal third of the shaft of the fibula, on the soleal line of the fibula, and also the midshaft of the posterior tibia. So this muscle does not cross the knee. It is simply a one joint muscle, meaning that it operates only at the ankle joint. And it operates at the ankle joint through its insertion on the posterior surface of the calcaneus through the combined and shared Achilles tendon. Now, the action of the soleus muscle is to produce plantar flexion of the ankle regardless of the position of the knee. So whether the knee is flexed or extended, the soleus is also always active. Now, this is in contrast to the gastrocnemius muscle, which becomes maximally active at full knee extension and less active with increasing angles of knee flexion. But the soleus is always active regardless of the position of the knee. So if we want to assess the functioning of the soleus muscle as an individual plantar flexor, what we do then is we minimize the effect of the gastrocnemius by flexing the knee. And that would help us to isolate and grade the soleus muscle if indeed there was reason to do so. So the soleus muscle is tested by having the examinee rise up on their toes with a flexed knee. Why is the knee flexed? Because with a flexed knee, the contribution from the gastrocnemius is minimized. And make sure to observe the presence of any inversion or eversion of the ankle. Those would indicate substitution movements, with inversion recruiting the tibialis posterior muscle, and eversion recruiting the peronei muscles, of which there are several, including the peroneus longus, peroneus brevis, and peroneus tertius muscles. Now, on testing resisted ankle plantar flexion, in the presence of normal and full strength, your examinee is going to be able to perform at least 10 repetitions of rising up on their toes with an extended knee. With grade 4, patient may be able to perform only 4 to 6 repetitions before failure. Now, we can modify a grade 4 rating with a plus sign if they're able to perform, say, 7 to 9 repetitions, with 10 repetitions qualifying for a grade 5. So this gives you some objective data with which to rely on in assigning your muscle grades. With a grade 3, subject is only able to perform approximately 1 repetition. Grade 3 plus would be 2 to 3 repetitions. A grade 3 minus would be able to complete only 1/2 of the range of motion, not even 1 complete repetition through full range of motion, or is able to perform only partial range of motion for several repetitions. With grade 2, the ankle is able to move but not able to complete 1/2 of the range of motion. In other words, it completes less than 1/2 of the range. And then with grades of 1 and 0, there is trace or no visible contraction of any of the ankle plantar flexion muscles. Other objective findings that you may see, and these are according to Palmer and Epler. In grade 5, the patient is able to raise the heel from the floor for several repetitions. Kendall and Kendall describe several repetitions as 4 and 5 repetitions, whereas Palmer and Epler describe 10 repetitions. Grade 4, we discussed, is 2 to 9 repetitions. With a grade 3, the examinee is able to plantar flex the ankle sufficiently to clear the heel from the floor. So that, according to Palmer and Epler, is a partial range of motion with no added resistance, and only 1 repetition. Palmer and Epler describe a grade 2 as having the examinee in the gravity eliminated side lying and non-weight bearing position, with the examinee able to plantar flex the ankle through complete range of motion. And grade 0 is no visible or palpable muscle contraction noted. And again, depending upon your needs or your findings, you can isolate the soleus muscle by minimizing the impact of the gastrocnemius muscle with the knee in flexion. But in general, to test the strength of the entire ankle plantar flexor complex of muscles, we would do that with the knee in full extension. Finally, let's talk about knee extension. Knee extension involves the quadriceps muscle groups. There's 4 muscles in the quadriceps muscles, and those include the rectus femoris, the vastus intermedius, the vastus medialis, and the vastus lateralis. The rectus femoris of the quadriceps is unique among the 4 muscles in that it's a 2-joint muscle. It has its origin above the hip joint at the anterior inferior iliac spine and superior rim of acetabulum. So it crosses the hip joint on its way down to the knee. The vastus intermedius muscle has its origin on the anterior and lateral proximal 2/3 of the femoral shaft and the distal half of the linea aspera. And the linea aspera, like the gluteal ridge, is an elevation on the posterior aspect of the femur bone to which this vastus intermedius muscle attaches posteriorly. It's around the posterior aspect of the femur. So the vastus intermedius wraps around the femur to the posterior side. The vastus lateralis also wraps around the posterior side, having its origin on the lateral lip of the linea aspera. It also attaches to the proximal aspect of the intertrochanteric line of the femur, and then also to the inferior aspect of the greater trochanter. The vastus medialis has its origin at the distal intertrochanteric line, also a slip from the medial lip of the linea aspera, and then approaching the knee it has a slip that comes from the proximal supracondylar line, and then also a piece that attaches to the tendon of the adductors longus and adductor magnus. And for those of you that have the PowerPoint presentation, I have a diagram that shows each of the four quadricep muscles, and points to note, key points are that the rectus femoris is a two-joint muscle, crosses the hip superiorly and comes all the way down to the patella inferiorly. The remainder of the three, the vastus lateralis, the vastus intermedius, and the vastus medialis, are all single joint muscles. But interesting is that the vastus medialis has its origin way up high on the lesser trochanter of the femur. And that's kind of counterintuitive, because if you look at it anatomically, the only part of the muscle belly of it that really shows is down towards the knee. So the bulk of the muscle belly itself is down toward the knee, but it does indeed stretch the entire length of the femur. So to test for resisted knee extension, we have the examinee seated, and we allow the examinee to lean back if necessary to unlock tension in the hamstring muscles. And tension in the hamstring muscles will build as the knee goes into full extension. So make sure to allow the examinee to lean back if they need to. Unlock the knee joint to approximately 10 degrees short of full extension for the isometric muscle tests. And in addition to sitting, these tests can also be done supine. I usually do mine supine, at least when I'm involved in testing knee extension with regards to lumbar spine nerve roots. You may want to do it either sitting or supine. In the sitting position, the subject is semi-sitting with the hip flexed 45 degrees and the knee flexed 90 degrees over the edge of the table, with support under the knee, support coming either from a towel or a pillow or something soft to reduce discomfort there. Apply resistance to the anterior surface of the tibia just proximal to the ankle joint, and this allows you to recruit a long lever in the application of your force, thereby taking advantage of mechanical advantage. And ask the patient to extend the knee joint at least through a range of 20 degrees or even into complete extension if they're able to do so. Now, in the presence of weakness, knee extension is going to interfere with activities of daily living, and some of these limitations or impairments you're going to be able to elucidate through either your history taking, through the medical records, or through the physical exam. So, for example, weakness in knee extension is going to interfere with stair climbing. It's going to interfere with walking up and down an incline. It's going to interfere with getting up and down from a sitting position. And those are exact activities of daily living that are described in the AMA guides, for which you will be questioning the examinee throughout your interview. And in one of our other programs entitled the Non-Physiologic Exam, I give you a procedure for integrating your activities of daily living assessment into the face-to-face meeting with your injured worker. So weakness to knee extension will be verifiable with positive objective findings, other positive objective findings on physical examination. And weakness results in hyperextension of the knee, not in the sense that such weakness permits posterior knee position, but rather that walking with a weak quadriceps requires that the patient lock the knee joint with slight hyperextension. So weak knee extension contributes to a gait disturbance. And you may determine that the gait disturbance qualifies for greater impairment than does the knee extension. And that's the latitude that you have as the examining doctor. So with grade 5 knee extension, we're going to see that the examinee is able to extend the knee throughout full range of motion against added resistance. Grade 4, the resistance that they'll be able to sustain is slightly less, and that can be modified with plus or minus signs. With grade 3, the examinee will be able to extend the knee throughout full range of motion, but without added resistance. So this is going to significantly interfere with activities of daily living, and you will know this long before you get to resisted knee extension testing. With grade 2, the examinee is in the side lying position, and the test leg is down against the table to eliminate the effects of gravity, and the patient will be able to extend the knee throughout range of motion without resistance, or if the examinee is in the sitting or supine position, they'll only be able to extend the knee through partial range of motion due to the added impact of gravity. With grades 1 and grade 0, we see increasing weakness. With grade 0, we're going to see no visible or palpable evidence of contraction of the quadricep muscles. And that qualifies as maximum impairment. And again, you're going to note this prior to actually even getting to this level of the examination.